in this very interesting IC, hot debates in cataract surgery. In our day-to-day practice, we come across many intriguing situations where we are in dilemma, which technology to use, which IOL to use. We are in dilemma. So the idea behind this IC is to move forward and not to stick to the routine situation, what we are doing routinely. Like, after this IC, there will be a clarity of vision on many issues that has not been addressed before, like pseudoexfoliation with hard cataract, with astigmatism, toric IOL or no toric IOL, a 50-year-old man with a clear lens, he doesn't want a spectacle for near vision at all. So presbyopic IPCL or clear lens extraction. There are so many topics which are new in this debate. And you will like it because these are never been addressed before. And I am the chief instructor of this IC. And Dr. Bharti Kashyap, myself, and our esteemed panelists are Dr. Harbans Lal sir, our immediate past president and a high-volume cataract and refractive surgeon. Dr. B.P. Kashyap, he is director of Kashyap Memorial Eye Hospital. He is also high-volume cataract and refractive surgeon. Dr. Krishna Prasad Kudlu, he is also editor proceedings and is a high-volume cataract refractive surgeon. Dr. Srini Ekdalan, he is also high-volume cataract and glaucoma. He is head of the Comtrust Hospital. Dr. Sharon D'Souza, she will be joining soon along with Dr. Harbans Lal sir. Dr. Sharon is the senior cornea consultant of Narayana Netralaya, and our speakers are Dr. S.K. Mitra. Again, he is from Jharkhand. He is the secretary of Jharkhand Ophthalmological Society and a high-volume cataract surgeon. Dr. Sujay Samanta, he is the past secretary of Jharkhand Ophthalmological Society and an eminent cataract and glaucoma surgeon from Jharkhand. Dr. Madhu Uda Raju, he is from Ramana Trees Eye Hospital chain head, and he's a very efficient cataract and refractive surgeon, and he presents very frequently internationally also. Dr. Nidhi Gatkar, she is a very high volume cornea surgeon from Jharkhand, young cornea surgeon. So as per the availability of the speakers, we have little reshuffled the topics. So our first topic today is pseudo-exfoliation. First, I will invite all the expert panel to the dais. I invite Dr. Virendra Sangwan sir. He is the Director Innovation, Shroff Charity Hospital, Delhi. Dr. Virendra Sangwan sir, please come to the dais, sir. Dr. Srini Ekdalan, please come to the dais. Dr. Sharon and Dr. B.P. Kashyap sir. Dr. S.K. Mitra. Dr. Sujay Samanta. Dr. Madhu Uda Raju. Dr. Madhu, please come.
Namaste, sir. He or she is struggling.
Dr. Vibhuti Bhushan, you can be in the panel. Okay, so the first debate is, if a patient comes to you with pseudo-exfoliation with hard cataract and astigmatism, so age-old belief is, oh, no, just go for monofocal, be safe, but don't go for toric. What will happen later with the zonules and the capsule? So Dr. B.P. Kashyap will be debating for toric IOL, and Dr. Madhu Uda Raju will be debating for the monofocal IOL. Let's listen to them. And then the expert panel in this is Dr. Srini Ekdalan. Dr. Kashyap.
Hi, friends. Thank you, Dr. Bharti, to have given me this opportunity to be in your IC. Can I have the slides?
Hello. And
No. It's not that. My slide has not come.
There is a problem in this conference. Whenever we are uploading,
We are uploading, yeah.
morning time also we had uploaded it had not come.
Review room.
Is there? Sharing. Dr. Pascalita, please check here. Please check here. Because they many times they don't send here.
ये ऊपर पर खोलो. एक मिनट. ये first. No. Second one. नहीं. Second one.
रोहित छोड़ दो.
Second one. So, friends, let's go very simple. The patient has got a pseudoexfoliation, hard cataract. Now, the hallmark of the pseudoexfoliation is the accumulation of the white or grayish flaky material all around the ocular surfaces. It could be in the iris or the anterior capsule, pupillar margin, and zonal fibers. Anywhere. So there could be some trans-elimination defects, and there could be some pigment dispersals and causing glaucoma. And these accumulation of materials, they cause weakening of even the lens capsule or even the iris zonular ligaments. So a lot of people, they develop glaucoma because of the pseudoexfoliation also. And there are systemic associations, and the patient should be recommended for regular checkups on cardiovascular assessments. So we are talking about the toric intraocular lens. It can be considered for the patient with pseudoexfoliation syndrome. The consideration what we look for is zonal laxity. Due to the inherent weakness of the zonals in pseudoexfoliation, you have to see whether the zonals are good or not, whether the pupil they are dilating or not, how is the angle, whether there's any abnormality or not, and of course the plate haptics are absolutely discarded. So an intraoperative technique should be more corneal incision should be given, because the pupil is not going to dilate fully, so you have to be a little more corneal. The choppers help at the incision site to prevent the iris prolapse. You have to keep the chopper at that site. I'll just show you in my video. The CTR should be ready, and it will give extra support, but only if there is some laxity of the zonal ligament. The iris retractor, the iris dilators or pupil expanders should be kept ready. Suppose if you have some problem, if the pupil does not dilate fully to your satisfaction. Everybody is expert to their own cases, so that in this case you cannot be able to do it. So be ready with this. Then you have OVDs, and you have the help of dilator to retract the iris while aligning the axis of the toric aisle. So you have to be prepared for addressing the phimosis, and IOL dislocation is essential. If pupil is manageable, a capsule is looking good, and yes, you can go ahead. So if you can put any, let's say monofocal. So if you can put a monofocal, you can put a multifocal, and you can even put a toric aisle. Why not toric aisle? So this is very small. We did, the patient had developed glaucoma, so we did the trabeculectomy pathway. It is a combined operation. You see, I'm giving a more corneal incision. It stopped. So we will see that the people did not direct fully, but then I thought I'll be able to complete the surgery in this, so I did not put any ring or hook or expanders, and the incision were quite corneal. And after doing the trab and not entering the anterior chamber, I started doing the phacoemulsification. The nucleus is very hard, by the way. I generate it at 4+++. The capsulexis was done with the help of the Varion, that is image-guided system, gentle hydrodissection, hydrodelineation, and direct shop method. The nucleus is pretty hard. So I can see that the capsule is so good, stable. So the zonules have passed the test. And then we complete the phacoemulsification. I always take out my Sinski hook when I eat up the last chunk of the nucleus. And again, I do the bimanual irrigation aspiration. You can see that the incisions are quite corneal. The patient could not afford the premium IOL, so I put them on economical toric IOL because I knew that he'll feel better. He will have a vision rehabilitation much better with this. And it was aligned with the help of the image-guided system. And then rest part of the trabeculectomy. And we have more than 6 years of follow-up. The patient reported to us after 6 years. So this was the undilated people, this was the dilated people, and the axis was there where it had put, but little bit of phimosis-like appearance. So lens is stable, so you can put the toric IOL. There's no problem. Thank you.
So now the Madhu Daraju is going to debate for monofocal IOL in pseudoexfoliation with hard cataract with astigmatism.
Thank you, ma'am, for making me part of this wonderful debate session. So why monofocal in pseudoexfoliation, and not only pseudoexfoliation, in this particular case, brown cataract is what has been mentioned. The sir has already enumerated the problems you have with pseudoexfoliation. One is poor dilatation, zonular weakness, and also a fragile PC when compared to the regular PC. And also, if you want to convert to an SACS and you know that you don't have good outcomes with toric IOLs, suboptimal outcomes are there. And correcting astigmatism need not be only in form of IOL. You can also choose a laser vision correction in form of cornea in these cases, which is more safer. So why poor dilatation poses a problem? Not everybody is as experienced and as skilled as BP Kashyap sir, and you don't have the digital marking systems. So maybe a beginner will have difficulties in even dialing the IOL into the correct axis with a small pupil, and also the bag is already weak. So in these cases, we have to be even more careful because the visibility is compromised. Coming to zonular weakness is a very well documented thing in pseudoexfoliation. Even with monofocals with 4 to 6 clock hours of dialysis, we try to put a CTR, and if the dialysis is more than that, you need to go in for SFIOL. So keeping all these uncertainties into place with an unstable bag, you always have unstable outcomes. Sometimes you can also have dislocated bags 3-4 years after surgery. And when you want to realign this whole system, it is difficult, especially when you put in a toric IOL. The only option you'll have it is to explant it and then put a monofocal IOL. So why not put a monofocal in the first place itself? Then fragile PC. So in these cases, there are high chances that you can have a PC rent. So in those cases, again, toric IOL will not be useful. So you need to place a monofocal IOL because the PCR chances are documented to be 3 times more in these cases. So option of 3-piece IOL and circus placement is more suitable for monoclonal IOLs or iris claw SFIOL. So this is one more point against putting this. And if at all you want to convert it into an SICS also, it has a good option here. So lesser endothelial damage, lesser jonular stress, and safer and predictable. And toric outcomes are satisfactory, but not up to the mark with these things, because you always don't know how the wound is going to heal and what the patient is going to end up with. So my option is don't do a toric IOL. Instead, finish off your surgery with the safest way possible with a monofocal IOL, and then go in for a laser vision correction. Wait for 4 to 6 weeks, assess the residual refractive error and astigmatism, opt for surface ablation. It's a simple and safe effective alternative to a toric IOL in these cases where you have multiple issues, not only pseudoexfoliation, brown cataract, small pupil, and all these things. So let us keep it simple. Let us not complicate things. Thank you for your time and attention. Yes.
So, Dr. Shrini.
Madhu, just listen to me. When you can put the IL, I'm putting the IL after seeing that the zonal ligaments are good. If it is good, why not? How do you say that is going to subluxate? Why do you say that the IL capsule complex will go inside? How do you imagine, sir?
They're good today, sir. Tomorrow we don't predict.
So let the patient enjoy that life, that good vision, for whatever time it is not dislocated. Ultimately, whatever you're doing now, you can do it later, sir.
Yes.
Okay, so the expert panel, Dr. Shrini.
Wonderful presentations, both of you. See, the thing here is pseudoexfoliation is a progressive condition. I would disagree with even Madhu in putting a CTR in these cases, because I've had at least 3 of the cases in which everything went down. With the CTR, IOL had to be taken off. So even CTR is not going to help in these cases. So my choice for intraocular lens in these cases is there are 2. One is put a 3-piece IOL in the sulcus and capture it. And if I have a 3-piece IOL, toric correcting 3-piece IOL, I would definitely go for it. Sir, as Madhu said, see, everything looks okay for. Sometimes it just goes off. So if there is a progressive dislocation, see, if that itself is going to, see, wherever it is staying where it is, that is fine. It goes off, it's going to be counterproductive. So that is one reason why, even if it doesn't go fully down and you have to explant it, the astigmatism correcting effect of the toric IOL is not going to stay there. So to correct it, I would go with Madhu in putting a monofocal IOL and go for a laser correction. Or see, up to 1 diopter, 1.5 diopters,
LRA.
if you are actually marking the steep axis and putting the incision there and put an opposite clear corneal, I think you can correct up to 1.25 diopters. You have to mark it previously. So that is it. And so I would prefer to go for monofocal IOL in these cases because it is not predictable. In what case, sir has wonderful hands, wonderful surgery, sir. But the issue is, what is going to happen after that is not in your hand. So I would go for a monofocal IOL in these cases. And sir has definitely shown that it is possible to put an IOL in this case. Even if it is a small pupil, you can, the axis placement and all can be done. No problem there. But with sir show that phimosis happening, with that phimosis happening, pulling on the zonules, and it's going to decenter. If it is going to. Sir's case, it didn't decenter, well and good. But the take-home message from my side would be to go for monofocal IOL, and if astigmatism is too much, go for a laser vision correction.
Thank you.
So, Sangwan sir, your take?
Yeah, I think we should understand in these eyes, the problem is with the endothelium and the zonules. So the idea is to give a long-lasting good vision to the patient. So if there are issues during the surgery, then obviously you may not be able to put the toric IOL or any kind of IOL. So think of, and also this phimosis or zonular dehiscence or rupture happens over a period of time, like in patients with uveitis. In patients with these patients, 10, 12 years, 15 years, it is the bag which falls off. So you need to look at a long term and then consider. And don't underestimate the spectacle also is a good correction. Not necessarily you have to do LASIK correction or a toric IOL. In eyes which are sick, residual correction with the spectacles is also a good option. Secondly, all patients may not have the same disease. It's always disease has a range, mild, moderate, severe. So you can make a choice based on what are you dealing with a given patient. Thank you.
Thank you. So the take-home message is we have to see the range, and as per the range of the pseudo exfoliation, we should decide. So thank you, the expert panel. So the next topic is capsular excess in intumescent white cataract. Suppose you have cataract in your own eyes or your mother's eyes. So what technique you will use? So today we are going to discuss the merit and demerit of femto versus Jepto, as well as the cost factors involved. So the first speaker is debating for Jepto, and is Dr. Sujay Samanta. And the second speaker is myself for femto. And the expert panel in this is Dr. BP Kashyap. And before that, I should introduce the expert panel, Dr. Krishna Prasad Kudlu. He's the editor, proceedings, and he's a very high volume cataract and refractive surgeon. Today we are definitely going to have some pearls of wisdom from him as an expert panel.
Good afternoon, everyone. I'll be speaking on Zepto-assisted capsular excess in intumescent white cataract. Basically, Zepto is an innovative disposable device that is used in cataract surgery that uses precision pulse technology method. It's accurate, it produces reproducible capsulotomy, which is quick, safe, and affordable. Bionis is a US-based company which marketed it in 2016 after FDA approval, and within months of its inception, it became so popular, and as a low cost and a better alternative to femtosecond-assisted laser surgery, and in present Indian scenario, it became very relevant. To understand how this happened, we must know a little about how this works. Basically, it consists of a silicon suction cup, a nitinol capsulotomy cutting element, and an incision push rod system. Nitinol is an alloy with a good memory function. It's an alloy of nickel and titanium. The console generates suction and brief train of electrical pulses. The undersurface of the device tip reveals the nitinol cutting ring, which is surrounded by the suction cup, and there is a retractable push rod which either makes it small or make it large depending upon the stage of surgery. This is the pictorial depiction. It has a console, a disposable tip, and this is the undersurface of that capsule, that suction ring made of silicon, and that metal ring, the nitinol cutting alloy ring. When compared to femtosecond, we can see how simple the machine is. And obviously, with simplicity comes cost, and its maintenance and its installation. Now, how it works? It generates, the handpiece generates suction and a brief train of electrical impulses. The undersurface, which I'll show an animation. The handpiece is inserted through a 2.2 or 2.8 incision, and that is done through the manipulating the push rod system. And once inside the eyeball, the anterior chamber, it is gently apposed on the capsule, and after centering it with first Purkinje image, suction is generated. And after the suction, optimum suction is generated, one can fire the electrical impulses, and that completes the capsulotomy. It is as simple as this. And when we are faced with this kind of cataract, that is intumescent cataract, we definitely want a result of this kind. This is something we don't want, but this is very quite common, and it can derail the whole surgery. So what is the solution? We can either go for a Zepto or a Femto. Both of them give predictable capsulotomy in this scenario. Now, what Zepto does is gives precision, and it does the process very safely. Why it is precise? Because there are no chances of extension, and safety because the capsular margin is quite tough, and it is predictable and reproducible every time. It is also suitable for patients with corneal opacities and small pupil, something which I have to think or it's not possible with femto-assisted capsulorhexis. And hence the patient gets a sharper vision with almost zero complication rate, at least related to the step of capsulorhexis. And the cost factor, I will come later, it is much less than what femto second laser cost. And obviously, the surgical time is very much reduced because the whole procedure, the electrical impulse, it takes about 4 milliseconds, and the whole procedure takes less than, I would say, 1 minute to complete. This is a surgical video. It is introduced through the incision, the push rod is withdrawn, and that suction ring assumes its shape, and it is gently apposed. Now it can be nudged gently under the iris because the pupillary dilatation is not adequate. And once it is apposed gently, suction is applied, and that we can make out by seeing the bubbles. And when the bubbles are seen and the suction is complete, see the bubbles moving out. When that is complete, we can fire the electrical impulses, which takes hardly 4 milliseconds to complete the cut, and the rhexis is done. This is all. It is simple as this. And finally, the outcome is this. We get a clear-cut capsulorhexis, well-centered, and with a proper overlapping of the aisle. Femto achieves the same thing, but obviously at a higher price. What are the advantages we get with Zepto, obviously there is a reduction in surgical time. It is versatile and it is efficient. The efficiency part we have already seen. Versatile because it can be used in corneal opacities. It can be done in small pupils. And in small pupils, Zepto is a clear winner with a win-win situation. And when coming to the cost factor, considering the present market rate, Zepto is it is only 3.75% of what a femtolasic costs. So it can be in the armamentarium of every cataract surgery, and every cataract surgery can extend the benefit of Zepto to every patient. And moreover, Zepto creates capsulotomy in one motion, which gives strength to the capsular edges also, whereas femtosecond capsulotomy, it creates capsulotomy in micro pulses, and there are chances of tear extension if not properly done. Pupillary dilatation, I have already mentioned, it should be at least 5 millimeter. Opacities and degenerations they have limited use, and cardiac patients on pacemakers, they can't be advised to go for femto-assisted capsular access. So these are the other recommendations which is not part of the topic. So the take-home message is that Zepto is so cost-effective and so efficient. It is well comparable to a femto-assisted capsular access, and it should be in the operating theater of every cataract surgeon. Thank you.
So the next, myself.
Now the next speaker is none other than Bharti Kashyap. She'll be talking about femto, how femto is better than Zepto. Over to you, madam.
Okay. Thank you so much. So, good afternoon, everyone. And my topic is capsular access in intermittent white cataract, the femto way. Why does anterior capsule tear and the Argentinian flag sign occur in intermittent cataract? There is a high interlenticular pressure with the pressure gradient, forward bulging of the anterior capsule, and whenever there is a nick in the anterior capsule, there is a certain scrutiny of the fluid with centrifugal force, and there is a pressure from the posterior compartment, and there is a radialization of the tear. What is the advantage of flags in this? There is a high lenticular pressure, there is a forward bulging of the anterior capsule. When we do flags, there are multiple fast circular perforations in a closed chamber, and squirting of fluid from multiple points, and this results to complete circular capsular opening, and if it is incomplete, then a drip and blue stain guided CCC completion. See here, in a closed chamber, there are multiple circular openings and squirting of the fluid from the multiple points. This is very advantageous, and this prevents the Argentinian flag sign. So this is a level 1 evidence that flags has the advantage of creating a circular and optimally sized capsulotomy in case of white cataract. The release of white milky fluid during femtosecond laser delivery is the most important factor affecting the creation of the free-floating capsulotomy. Multiple simultaneous fast perforations with multiple point squirting of fluid is the best advantage of femto. The closed chamber with no pressure gradient and the triple blue guided completion is when it is required. Choice is yours. So what is the jump of cost? From ECC to phaco, 2,000 times. Did you not opt for phaco? You did. So the same way, the phaco to flags is only 20 times. Any technology has higher cost in the initial stage because of many factors. As the technology becomes more widespread, the cost of the consumables reduces significantly. The same will happen with the cost of PI. Nowadays, there are several common platforms where any surgeon can hire the facility of this technology without investing in this, so the cost can come more cheaper. So
Luminescent cataract with
this is
the
the
perception of light in the left.
This is the this is the experience of India's one of the topmost surgeon of the first case in the Zepto. Yes, this one play.
A Zepto capsulorhexis and proceed for.
This is our first case. See what is happened.
Suction radial manipulation. Care was taken to place it carefully, onto which gentle suction was applied, which was visible as a lightning flash. Simple. This was the first time I was using a Zepto for a capsulorhexis, and it was being demonstrated. I was told that the suction. I put in a second instrument and tried to break the suction. However, that was not possible, being dangerously at the 6 o'clock position, tubing. And lo behold, this was visible with the gush of fluid and viscoelastics through the side port. The vacuum was released, and to my relief, I was able.
So this technology also has some inherent complications which we should know. Now some humor.
अरे एक प्लेट बिरयानी दो यार। और सुनिए बढ़िया बढ़िया लेग पीस डालना। हैं? लाइए, ये लीजिए, थैंक यू। अरे बड़ा कमजोर लेग पीस है। इस मुर्गी को पोलियो हो गया था क्या? अरे 5 रुपए में क्या हाथी का लेग पीस मिलेगा? चुपचाप खा ले। ठीक है, ज़्यादा ताव मत खाओ। बट कमजोर है लेकिन है बहुत बढ़िया। क्या हुआ भाई? दरअसल हम जब भी हिचकी ले रहे हैं, अच्छा, कौवे का आवाज आ रहा है भाई। क्या खाए थे? दरअसल हम 5 रुपए वाला चिकन बिरयानी खाए। 5 रुपए वाला चिकन बिरयानी? भैया वो कौवा बिरयानी है। अब खाइएगा कौवा बिरयानी तो मोहम्मद रफी जैसा आवाज थोड़ा ही आएगा। कौवा बिरयानी?
Have some fun of OPL. Thank you, thank you. So I invite Dr. Kudlu for the expert opinion.
Yeah, there are two different technology altogether actually fighting. But if you ask me for my first question to Dr. Sujay, what you showed the photo of Visumax. Actually, Visumax never do a femto cataract at all. That is a purely a refractive machine. It does the only lenticle extraction. It never touches the anterior capsule. There is the one point I just wanted to clarify. There are only 4 equipment in the market. That is, one is a Lensar, other one is Lensex from Alcon, and also from one is from J&J, that is Catalyst, and Z8 from Zimmer. These are the 4 machines which does the femto, as far as I know. Volume, but these femto machines compared to the femto of the refractive surgery, which is smaller. I do have got a Lensar machine which I can move from one OT to other OT very easily. Only one person can. Smaller machine. But apart from that, whatever the my argument with you, of course, as far as the capsulotomy is concerned, Zepto may do the good job. But when you tell the patient, when you opt for a very premium surgery, always you need to have a perfect goal. That means along with the capsulotomy, if you are the patient already having a grade 4 cataract intumescent, sometimes when you do with the phaco, the chances of nucleus may drop down. But if you do with the femto along with the capsulotomy, then all the nucleus will be divided, and the overall surgical time and of course the quality of the surgery also will be there, and also you are going whatever the intended result, that is with the whatever the best lens you opted, you can put. I am not telling that with Zepto you can do good phaco, but there is a chances of complication might be very high whenever there is a grade 4 cataract with the intumescent. There is one possibilities. So thinking on the account, if you think about patient, of course money might be little definitely it is much expensive. Here you need not have to invest per packs, only have to give. But if you're talking about quality, I think my personal view is definitely femto has got an edge over the Zepto. If you are doing with a group practice, suppose there are a lot of places, 20 doctors together, they put a femto, then I think it works almost similar to the Zepto. This is my view. Of course, for capsular axis, both of them work well, but capsular axis not at the end of the surgery. Then we have to proceed with the phaco. That is the main part. Suppose if you are having grade 6 cataract, just do capsular axis is not so sufficient. You need the nucleus also to be managed well.
This is for intumescent white cataract. So white cataract.
white cataract.
Yeah,
If
this
you
is
ask
only
me,
for intumescent
yeah,
white cataract.
intumescent white cataract. In fact, intumescent white cataract with the hard nucleus inside also, my preferred will be femto. Yeah.
So, thank you, Dr. Kudlu. Our third topic
May I
is...
add one thing? Even while doing a femtosecond laser-assisted cataract surgery or cataracts, if there is a intermittent cataract with high intralenticule pressure, the moment the first few shots goes, the capsule ruptures and fluid comes out from the lens to enter the anterior chamber, and immediately the depth is little different. You see, so many a times you'll find that you have to be very, very careful. You have to increase the amount delta that is above the capsule and below the capsule so that you get a proper this thing, because after repetition it might become all right. So you have to be very, very careful while doing femto also. And in Zepto, if there is a shallow chamber, you have to be very, very careful, and it is not only the insertion, even the removal of this Zepto is risky. But then if you compare both these, both are good.
Sangman, sir?
Yeah, I just want to say that other than both these two techniques, the manual technique, if you are skilled and if you can manage, is not a bad idea, because both of these add additional cost to your surgery. So those of you don't have those devices, doesn't mean that you can't do a good surgery.
The only issue here is if you're going for a premium IOL, toric IOL, and all for IOL placement, you need a proper access. So that's the only issue. If it is a monofocal IOL, you can go with manual.
So nobody is talking about the cost.
But that's what I'm saying now. See, you have to, first of all, you have to have these devices in your practice. Then is the question of choice comes.
Accessible to very limited surgeons.
Absolutely, absolutely. Very, very limited surgeons, and I think it's a much more costly surgery.
Yeah, so you can send those patients to us, no problem.
So our next topic is Fuchs with early cataract. So Dr. Madhu Uddaraju will be debating for combined surgery, and Dr. Nidhi Gatkar will be debating for only cataract surgery. And the expert panel is Dr. Sharon D'Souza. I invite her to the dais. Dr. Sharon is the senior cornea consultant of. Please come. Oh, there is a chair. So Dr. Sharon is the senior cornea consultant of Narayana Netralaya. So we are sure we will get some pearl of wisdom. So over to Dr. Madhu Uddaraju.
Thank you, ma'am. Thank you once again. So why I preferred combined surgery in Fuchs with cataract, no financial disclosures. So point for combined surgery are cataract surgery, however early your cataract maybe, will hasten the decompensation and cause damage to the already compromised endothelium. Staged procedure will definitely have suboptimal visual outcomes because things are not in your control. You can't plan the IOL calculation and others correctly. And with a combined procedure, you'll have relatively predictable refractive outcomes, and there are also logistical advantages to this. So if you see cataract surgery itself, as I've told you, hastens the decompensation in Fuchs dystrophy. Several studies tell that there is a 25% cell loss is inevitable. However, low phaco energy you use or because of the BSS that goes into the eye and irrigation that happens. And there is definitely a need for DMEC or DSEC in these cases 3 to 10 years down the line. It is not like a standalone surgery and you're going to avoid transplant altogether in these cases. So why suboptimal visual outcomes? Because you see, with the cornea that is already compromised here, you already have reduced contrast sensitivity and glare corneal because of the corneal edema that is there. So however good IOL you are going to put, the visual outcomes are not going to be great. And there is also, you'll have challenges in IOL power calculation, especially when there is an unstable ocular surface. And best of the IOLs cannot give you good outcomes and the patients will be dissatisfied. Compromised cornea and ocular surface, and post-op also the corneal edema may increase, leading to further complications in the visual outcomes. So how can we do a more predictable refractive outcome in combined surgery? There is a technique called as constant optimization in the IOL formula that you can use when you're doing a combined DMEC with cataract. This has more predictable visual outcomes. And when you're planning for a DSEC, you already know the hyperopic shift that it is going to cause. So depending upon this shift, you can calculate the IOL power and give a better outcome. With PCIOL in place, emmetropia cannot be achieved. If you're already doing an PCI is already there, then you go in and do a DMEC or DSEC. You don't have control over the visual outcomes. So combined procedure, this calculation can be pre-planned and you can have better outcomes. So logistical advantage, the surgical cost is definitely optimized because you're doing in a single sitting. Cost also is less when that is incurred by the patient. Lesser post-operative visits, at least come down by 50 to 75%. Otherwise, you do your cataract surgery and keep calling the patient till he develops a compensation, and that is going to take longer, and then you do a DMEC or transplant and then again post-op visits. Now that in between time you are reducing here, so that reduction is also important, and it's a permanent solution. And especially when you're opting for lamellar procedures, there are less chances of rejection when DMEC and DSEC when compared to PKs. So why choose a surgery that is built to fail? So instead of that, go in for a combined procedure. Thank you. Thank you for your time.
Dr. Nidhi is a very high volume cornea surgeon from Jharkhand. So she is debating for only cataract surgery.
A very good evening to all of you. So I would be talking about cataract surgery alone in a case of Fuchs with early cataract. So now there is a classification for this corneal dystrophy depending on the vision loss, symptoms, and the clinical findings. Also, there is a slit lamp classification by Crackmer on the confluence and number of gut data. This is how a classification and grading would look on a specular microscope. And now there is a newer classification on topography where we see that the displacement of the thinnest point of cornea is there. There is loss of parallel and circular isopax, and there is a focal area of posterior surface depression towards the anterior chamber in such cases. Another newer classification has come on OCT findings, where we see that there is another grade known as subclinical stromal edema, in which on the pachymetry we see that there is a negative value in the central cornea, which is detected by the posterior elevation map. So now, if we have this subclinical stromal edema, we need to see if we have to do a sequential surgery or a cataract or a combined surgery. Another thing that we need to see for a patient to decide if only cataract surgery or a combined surgery should be done is the central to peripheral thickness ratio. It correlates with the clinical grade of FECD. Corneal densitometry also helps in determining the decision for sequential or combined procedure, and it correlates with the post-surgical BCVA after DMEC. So when to do a cataract surgery only? Well, there is a full algorithm. First, you need to look at the slit lamp, see if what is the grade of the cataract, what is the edema. Then look if there is any absence of tomographic features. If the cataract is significant, there is mild FECD, no edema, then a careful cataract surgery only can be done first. And when to do a combined surgery, there have been cutoffs earlier saying that if the cells were less than 1,000 per millimeter square, then go for a combined surgery. But in these cases, it is difficult to measure the cells actually in the specular microscopy. And also, a cutoff was earlier made of 640 microns, in which either a EK or a combined surgery should be done. But there can be normal corneas without edema who also have this thickness, or thin corneas with clinical edema, which can be actually thinner than 640 microns. So how to decide? Also, FECD patients with advanced diseases have 31 to 58 micron thicker pachymetries in the morning, and which would resolve over 4 hours after eye opening. So the time of measuring of CCT is very important, and that should also be considered to improve the reliability of testing and decision making. So if we do only a cataract surgery, lesser ultrasound energy will be used to remove the cataract versus if the cataract becomes denser, and thus lesser endothelial damage. It is less stressful for the patient knowing that he is only going for a single general cataract surgery, not an EK procedure. It is less stressful for the doctor because it's technically easier. Lesser inflammation, lesser endothelial cell loss, better pupillary constriction for future EK, lesser management of fluid misdirection due to phacoemulsification, and the anterior chamber will later on become more stable because of adhesions of the IOL and bag, and thus we will have to face lesser difficulty of positive vitreous pressure for EK. And some of these cases might actually not require an EK for a very long time. A study showed that there was no difference in visual acuity improvement in sequential DMEC versus DMEC triple, and also there was less endothelial cell damage after DMEC only versus a DMEC triple procedure at 1 month and 1 year. So considerations during cataract surgery, that the IOL should be within the rhexis margin to keep it in place, longer tunnel length, all the chopping should be done in the bag or iris plane, stay away from the endothelium, use a soft shell technique, reduce the AFR, and keep the residual astigmatism, refraction on the myopic side, which is minus 1.25 to 1.5 for DSEC and 0.75 for DMEC. Also, proper counseling is a must that corneal edema may develop and you might require an EK procedure in future. After cataract surgery, we can use Rho kinase inhibitors. These improve the topographical features. They also reduce the preoperative subclinical edema, reduce the post-op cell loss, and might actually postpone EK. So we have SICS, phaco, and femtosecond assisted cataract surgery. This, the cumulative dissipated energy used here is lesser phaco time, better effective lens position. So a case study showed that the refractive outcomes in early and late follow-ups was similar in conventional and femtosecond cataract surgery, but the spherical drift was more in conventional than femtosecond cataract surgery. So this is a personal case of a lady having bilateral fuchs. Vision was similar, specular microscopy and cataract grading was similar. Both eye underwent flax. The right eye over 1 year worsened to 5/60 from 6/18. Specular did not have any reading, so she underwent DSEC. Now, after 1 year, her BCVA actually is dropped down. It is 6/24 because she had interface haze. The other eye, on the other hand, is doing good with 6/9 on Ripasudil. So there are a lot of complications that can happen during cataract surgery. No matter how experienced you are, what about them? Because sometimes when you try to do something very good for the patient, you might end up with a very bad complication. So a surgeon should be very careful to work on the craters of Gatteta. Thank you so much.
So as with the information is very clear. So first I asked Dr. Sharma D'Souza for an expert coming, and we welcome our first president of the first answer.
अरे अभी इमीडिएट पास नहीं, प्रेजेंट हैं अभी ये मीटिंग इन्हीं की अध्यक्ष में.
So Sharma, please, you are an expert coming. I think both presentations.
थोड़ा प्रेस करके रखना चाहिए बस.
So I think both presentations were excellent, and I know both are really great surgeons. So that always is a criteria as to how comfortable you are with whatever surgery you're advising. I would think that would be one of the primary criteria. Now, one thing we must know, as the topic is a little ambiguous because combined surgery in fuchs with early cataract. We have to understand whether you're talking about an early fuchs with early cataract or a fuchs, which is a mid-moderate range like the one Dr. Madhu showed, but the cataract is mid-range, or both are mid-range. And the decision making would depend a lot on where you're ranging. I agree with Dr. Madhu, the case which you showed is a case for a combined because as you saw, there was already stromal edema there, and that is one of the criteria where you definitely have confluent guttae, which you'll see on slit lamp examination. The specular is not going to pick up any cells in that region. It's right central. There is stromal edema, and it's definitely going to get worse. However, the case which was shown by Nidhi, Dr. Nidhi, is one of the early cases, and there, yes, you would go ahead with doing a cataract surgery, because I agree that what you said, not all of them will progress, and if they do, some of them progress very, very slowly. 10 years is a very long time. There is no need to rush and do a surgery now just because the patient may need a surgery after 10 years. That would not, is not required. Pachymetry and the topographic changes are what most of us look into now, in case you're not able to get cells, which very often you don't in these patients on the specular. And that article which you showed about grading and deciding, that algorithm is, again, what we follow and is very, very useful for anyone who would like to look into deciding. But yes, at the end of the day, it depends on what surgery you're comfortable with. If you are a cataract, a corneal surgeon who's very, very good at endothelial keratoplasty, it is obvious that even if you do a combined surgery, your results are going to be great. Whereas if you're not that competent, then you may have all the complications of an endothelial keratoplasty and land up with worse vision. And sometimes even with the best of surgeries, with grafts, some things are unpredictable. So always weigh both sides. It's never a hard and fast rule in terms of these conditions. Look at it very closely at what grade of cataract and what grade of Fuchs, and then take your decision.
Can I make a small comment? Also, like what Saren says is that at what you are comfortable with, ask the patient what is their preference.
Absolutely.
Some patient may not want a DMAC or DSAC.
Yeah,
they say, please do cataract surgery first and let me see if I'm okay with it.
Exactly, sir. Yeah.
Thank you, sir. So our next topic is 50-year-old wants a spectacle independence. What will you go for? Clear lens extraction or presbyopic IPCL? So our president, sir, Dr. Harbans Lal, sir, will be speaking for clear lens extraction. Over to you, sir.
So good evening, friends. Sorry for being late, and thank you, Bharti, for giving me this opportunity. And thanks the chairpersons. So I'll be talking about the clear lens extraction at 50 years old male. So what are the issues when we are trying to remove the lens? Is it safe? Do we have the accurate biometry possible? Can we take care of the astigmatism? Can we take care of the presbyopia? Can we manage the complication and comparison with the IPCL? So we know that this surgery is absolutely safe with the improved fluidics. Power debris is hardly any in these cases. Anesthesia is topical, so there are no chances of globe perforation. The eye square is very few patients need the YAC capsulotomy now. Accuracy of the biometry has improved so much that we are sure to have 85% of the patients within 5.5 diopter of the post-refractive error. And astigmatism is well established, and excellent results now can be achieved with the toric IOL. Even up to the toric IOLs are available, which can correct up to 0.67 diopter of astigmatism. Beyond one, we used to always correct. And so far as the presbyopia is concerned, there are multifocal, trifocal, and EDOF lenses, mini monovision, micro monovision. So there are many ways to make the patient spectacle independent. And I'll show you one of the things, like suppose you are using a Synergy, which type of a lens, which is gives 0 to 33 centimeter of a distance, full range coverage. If you are using Symphony and Vivity type of a lens, it gives you intermediate and a distance. If you take the premium monofocal, it gives you around 0.5, 0.75, and the monofocal just at one point of time. So whatever lens you are using, there has to be a combination in that. So whenever you are using a Synergy lens, never target the myopia, because then the near point will come too close from 33 to 25, which will be uncomfortable for the patient, and patient will have less vision. But even if it is a plus 0.25, he will have excellent vision for distance, and is from 33 to becomes 37. So whenever you are using the high power near lenses, always target around little plus or emmetropic, very close to plus minus 0.25, not beyond that. While on the other hand, you are using Symphony and Vivity, you can have patient little bit of a myopic. If it's slightly myopic, his range, which is around 60 centimeter, 70 centimeter, will come closer, and he will be able to read better. And you can also target one eye at a distance, another eye little minus 0.5 to give him the full range of vision. And whenever you are looking at a premium monofocal, if patient is wanting only best distance vision, then you use it as a synergy. That means one lens may be a little slightly, even on the plus side, it will give excellent distance vision because it has got a landing space over there. So use it, and if the patient wants a little bit of intermediate vision, then use it like a symphony in beauty, that one lens becomes minus 0.25, another becomes minus 0.75, so that he can have easily, and with the addition of 0.5, 0.75 of the lens, patient can cover up to 60, 70 centimeter very well for the intermediate range. And we know that the monofocal lenses depends upon, again, there are the two types of lenses. Use it like a synergy, that means absolutely if he wants for distance, and you can have a mini monofocal to give the patient a near vision as well. So irrespective of the type of the lens and the patient's affordability, you can make the patient's spectacles independent depending upon his need. The only complication of the myopia is the retinal detachment, and there are AO guidelines that if there is asymptomatic lattice with or without holes, operculated atrophic holes, no treatment is required. Monthly follow-up for the first 3 months, 3 monthly follow-up for 1 year, and the 6 monthly follow-up. Symptomatic PVD with no breaks, no treatment, 1 to 8 weeks, then every 6 to 12 months. So that means there are guidelines. If you do the myopic lens exchange, you have to follow these patients at least for 2-3 years very regularly and sincerely to look for the retinal detachment. And pseudophakic myopic eye is 3 to 6 months. So you got to look for, and once the PVD develops, then chances of retinal detachment becomes much less. Most of the myopics will have a PVD over there. On the other hand, whenever you are getting the hyperopic patients, then it is absolutely a plus point because the IPCL may not be a good choice, particularly if it is shallow. These patients are more predisposed to glaucoma, and this gives the best outcome, particularly if the patient is slightly hyperopic. He'll be more than happy because his distance vision, near vision can be taken care of, and the incidence of glaucoma also goes down. And the complication of retinal detachment, CME, CME, all these are minimal in hyperopes as compared to the myopes. So the problem of the phakic eye ulcer, the cost, the chance of glaucoma, chances of inflammation, infection, retinal detachment, halos, cataract development, endothelial cell loss, all of them are more than the cataract surgery so far as the IPCL is concerned. So halos in optic diameter of 4.9 millimeter, size of ICL which is 12.1 size, and 5.8 is the optic size when the IPCL is 13.7 millimeters. So the smaller the lens, more chances of halos in these patients. And there are more chances of the cataract development in these patients, and there are more chances of endothelial cell loss, 1.8% cell loss per year. In 3 years, 8.9%, 5 years, 11%, and 6% they lost nearly 30% of the endothelial cells over a period of time. So to conclude, RL is a good option, particularly for LASIK and ICL unfit patient. If the age is above 45, this patient is at 50 years of age. Hypermetropes, it gives the excellent results. Myopes, you have got to be careful, and regular follow-up is required so that the patient doesn't develop the detachment. And if it develops the detachment or the holes, it can be treated timely. And toric, multifocal, trifocal, monofocal, mini monofocal, there are many choices available to us to make the patient spectacle independent. And this is lifelong freedom from spectacles, and the patient won't have to go for the second surgery of the cataract. Thank you very much for your kind attention.
Thank you, sir, for the fantastic talk. I think how Dr. Madhu Uddaraj will really counteract a patient with 50 years old age with a clear lens. He doesn't want to touch the clear lens, rather he wants to put a presbyopic IPCLs.
I don't know what ma'am has against me, sir. She made me debate against Kashyap, sir, his daughter-in-law, and now the president of AOAs. So, sir, I did not choose it, so don't, it was an option. Right, so spectacle independence for a 50-year-old. So 50-year is the keyword here. And why presbyopic IPCL in these cases? No financial disclosures. So my point is, when you are self-telling it's a clear lens, why do you want to touch it? And why don't you choose a procedure that is reversible, that has better predictability, that has better visual recovery and faster adaptation? And also, if the patient does not adapt, you are having an opportunity for a second chance you are giving here. Their chance is taken off. So clear lens, so these are a lot of articles like sir has quoted now some. I have some articles. which tells that there is no point in touching a clear lens. 50 to 55 is a gray zone. Above 55, there is no argument, but 50 still has a very high risk of retinal detachments and also macular problems. And Douglas Koch, I think he is also in an opinion that it's better to delay clear lens exchange until 55 as the complications are more, and he is not still satisfied with the choice of multifocal IOLs or refractive IOLs we have in the market, because what we see 10 years before is not what we see today. So if you are giving this patient that additional 10 years, the technology may also advance. So reversible. So whenever the patient is unhappy in these situations, it's very easy to explant an IPCL when compared to an IOL that is in the bag. And you still have a reserve procedure in these cases if the patient is not satisfied. And this experience can help you choose a better IOL in the future. Suppose the patient is not happy with a particular diffractive IPCL or a need-off IPCL, then you choose the other technology for an IOL. So that is how it is useful. And predictability and visual outcomes also. When you see, though both RLE and phakic IOLs have very good outcomes, visual outcomes when compared to RLE have better in cases of phakic IOLs. These are all the references that tell that the visual outcomes are better, because here you are not touching the natural optical system. You are just adding a lens before it, and there is no adaptation time for this new optical system. And almost immediately post-op, the patient can read. You can see the wow factor. There is no neural adaptation time, as it's an adjuvant to the natural lens that is there in the eye. So, and also, as I've told you, the last point is opportunity for better technology. There is a decade of opportunity that you are giving to the patient. Now, no longer we are using restore. Probably 10 years down the line, you are not going to use your PanOptics or Vivity. So, multifocal IOLs, even today, are still evolving, yet to get a perfect design. So, I would prefer a irreversible and less invasive technique of phakic IOLs in these cases. Thank you for your time.
Oh, really? The expert panel is Dr. Kudlu.
So may I comment one?
Yeah.
So I think Madhu is richer than me because he's looking for a versatile technology so that he can operate patients many times. I think you should also look for the ICL, IPCL, or the IOL, which actually degrade in 5 years' time, so that we can keep on operating same patients every 5 years. So that will make us much more richer. So the basic that you are looking for reversible technology, that means do not trust the technology.
Yeah, as a panel, I got a different view. 50 years old patient, no cataract. If the DLI shows that more around 10, my option is going to be press beyond. If the corneal refractive surgery, if I can do, press beyond is my best option. Patient do really well. But here the debate is between the clear lens versus the IPCL. Of course, I have to stay in general council. I have to stay with my president. He is the most important person for me. Okay, so, but apart from that, in fact, you are right that we are not touching the clear lens, so chances of retinal detachment will be definitely much lesser in IPCL. But there are patients with presbyopic IPCL also developed retinal detachment. Also, patient complaining of something, a black round object in front of eye, and also they got a glare and halos. But in comparison to these lenses, the complications of presbyopic IPCLs with the clear lens extractions are almost glare and halos are almost the same. Comparable. So in such cases, I think what Sir says that I think once for all the surgery, give him the best. I think my hat is towards the clear lens extraction lenses, Madhu.
Dr.
Please wait, jab baith jaiye.
Please sit. We'll give the mic. Please give him the mic. Who is he? God. क्या हो रहा है?
कैसे he has come? अभी आ गया. He's asking question.
Why the doctor are
Very good question, sir. He's asking why the doctors are wearing specs while they are performing surgery on others.
Yeah.
Hello. So I think
why all doctors are wearing specs? You are advising IOS to the cost of a patient?
No, so so far as if you see many of my colleagues who have been emetropic, I'm giving you the answer. Just please wait. Many of my colleagues who have been emetropic since childhood, once they become presbyopic, I had a Dr. Anita Sethi, now Tinku Bali, and there are so many others. Once they become presbyopic, they find it very, very difficult to use the glasses because they never had habit of using glasses. So every time they keep on searching in the bag whenever they need to read, they keep on searching in the bag where the glasses are. So how you want to feel and just feel and look like is entirely your personal prerogative. So some of the patients do feel that they don't want to use the glasses. They are more than happy to go for it. But these surgeries are not forced surgeries. We do not force the patient to.
Unka question सुन लो. He is very restless.
Question तो यही है ना कि क्यों
डॉक्टर ने क्या? He says something else.
Question from born what the choice of you? 20 years old boy having specs. Why he go for
अभी टाइम इज ओवर.
नहीं सर, क्वेश्चन ये है, नहीं मैडम एक मिनट. देखो सर, सर्जरी जबरदस्ती नहीं करते हैं. जो पेशेंट आता है, जो चाहता है, उसके लिए करते हैं. नॉट इट्स रिकमेंडेड.
We don't recommend. Actually, some of our friends, ophthalmologists, also underwent presbyon. Sri Ganesh is the best example for that. I only moderated his surgery. He has done presbyon almost 10 years. He's got 6.6 and 5.
So these surgeries are
already we are given the conclusion. The best in this debate, I think Dr. Harbanslal has got a upper hand, that clear lens extraction. Okay, let's go to the next debate.
Next topic is
compulsion समझ सकते हैं.
Yes. The next topic is unilateral cataract. So, will you go for monofocal or trifocal? So, Dr. Subrato Kumar Mitra will be debating for trifocal. He is Jharkhand Ophthalmological Society secretary also. First monofocal कर दें. And the discussant, the expert panel is हरबंस लाल sir.
नहीं मैं चल रहा हूँ.
अच्छा आप जा रहे हैं तो ओके ठीक है. डॉक्टर श्रीनी है there, डॉक्टर कुडलू there. So first monofocal IOL, Dr. Sujay Samanta. He is from Jharkhand and a very high volume cataract and glaucoma surgeon.
I think he's fine.
He's fine.
Good afternoon once again. When we have to operate on a unilateral cataract, we are faced with three types. Three types of IOLs we can implant, either monofocal, multifocal, or extended depth of focus lenses. Now, before considering which lens to implant, we should know what a normal human optical system is, because we should work in accordance to what the nature wants and what God has given us. So a normal human lens is basically aspheric. It gives high contrast, glare and halo-free vision, and it has unrestricted field. So if you consider this point, and if you look into two more things, the optical principle of how a monofocal works and how multifocals work, we find that monofocals, they have a clear single focus point. Almost 100% is light is focused at that point to clear a crisp image, whereas in multifocals we see there are multiple foci and the light entering gets distributed through the different zones. Now, how it is distributed? It is the very lens design that the central part is the intermediate zone, and the mid-periphery and the periphery, they work for distance and intermediate, distance and near. And they distribute the light distribution in accordance to give a mixed type of like trifocality, distance, near, and intermediate. So obviously, the same source of light gets distributed into three zones, and as far as I know, it is 60-20-20 ratio. So what are the consequences of this? The consequence is that with monofocal we get a crisp image, sharp image, light is not distributed, and the very lens design of multifocals, they induce a very disturbing effect which is known as photopic phenomena. That comprises of a lot of things which I'll deal later. Now, asphericity is basically that is promoted. It is promoted by making the lens surface not equally curvilinear, making the periphery flat. The basic aim to make a lens aspheric is to reduce spherical aberration and create a single clear image. And similarly, contrast sensitivity, which adds to the quality of vision, it is defined as brightness of an image and the background distributed by the total brightness of image plus background. So again, as we have seen in multifocal, as the light gets distributed, the contrast is compromised in mesopic conditions. Glare is something, again, it has to do with the lens design. Because there are multiple zones, multiple rings, light at certain points get diffracted, refracted, and ultimately they create a separate source. Now, the glare is defined as when a light source other than the target image, it is something extra we don't want, and that image causes glare. And this indirectly reduces contrast and scatter. So this is a simulated diagram to show how clear and crisp an spheric image is. The whole hype of multifocal, even with the near vision, you see the quality of a corrected monofocal lens N6, and you compare it with a multifocal N6. If the patient is asked to read the lines, they will read the line, but there's clear-cut, there's a difference in the quality. Or the images are fuzzy and the words, the margins are indistinct. So what is the practical implication in the daily life? They have trouble driving at night. They are not able to, the housewives, they can't do their daily chores. They have to use a lot of, there's a lot of eye strain while watching TV, computers, and all those things. And they need more light to read in mesopic conditions. So finally, when we go into the disadvantages of monofocal, because of light distribution, the quality of vision is compromised. There is more photopic phenomena when compared to monofocals. Multifocals, they have more photopic phenomena. Glare is, the percentage-wise I'm coming, this is the percentage of disturbing features a multifocal patient have. As many as 79% patients, they have halos, and 80% they have positive dysphotopsias. And these are the bouquet of complications we give to the patient after we implant a multifocal, nighttime visual problems, difficulty with driving. These are the various like image simulations, I'm seeing the starburst, the halos, So ultimately, at the end of the day, if we go for a monofocal, we give peace of mind to the patient. The patient won't mind wearing a bifocal or a progressive spectacle just for the sake of getting multifocality. And we as doctors, we wait for neural adaptation with fingers crossed. Thank you.
Good evening, everybody. Thank you, Dr. Bharti Kashyap, to giving me the opportunity. Now, my topic is to defend trifocal IOL implantation in unilateral cataract. So, in disclaimer, I should say I have no personal interest or personal preference to any person or product, no financial disclosure, and purely what we will be talking on my personal opinion backed by literature and personal experiences. The Herculean task to argue Dr. Shuja because he is a well-known personality in Eastern India and experienced, versatile, high-volume fecal surgeon. The various presentation of unilateral cataract is associated cataract in congenital syndrome, secondary cataract, traumatic cataract, most common cause in young individuals, posterior subcapsular cataract, pediatric cataract, and idiopathic cataracts. The unilateral cataract causative factors, if you look into, these are asymmetric aging, glaucoma, or uveitis. Rate of progression may differ in the prolonged use of ultraviolet radiation from sun, smoking, of course, corticosteroid, diabetics, trauma. Usually younger patients more adaptable, and in case of more than 50, second eye to be done at an early stage. These are the different presentations of the unilateral cataracts. Now, when you think about and ask the patient, what do you want actually? We should ask the patient, what do you want? The patient invariably, the answer is the spectacle independence. Now, how to get rid of the spectacles? There are various literatures. The literature says the unilateral implantations is a very good literature evaluation of vision-related quality of life after unilateral implantation of trifocal intraocular lens. The unilateral implantation of trifocal IOL is well tolerated with good patient satisfaction, assessed by visual function. 14 questionnaires in subject to that the cataract have in one eye, encouraging single-eye surgical procedure in this particular group of patients. There are other literatures like the rate of complete spectacle independence with trifocal intraocular lens. This meta-analysis of 13 unique clinical studies demonstrated that at least 9 out of 10 patients receiving trifocal IOL during cataract surgery can expect to achieve complete spectacle independence. Now, the congenital cataracts, the exclusion criteria are the glaucoma, retinal pathologies, and systemic problem, of course, but the trifocal IOL implantation should be considered as an alternative to monofocal lenses in selected cases of pediatric cataract where amblyopia is not subjected. So, the one more study is a good study, the trifocal toric intraocular lens implantation in pediatric traumatic cataract, which says that in careful selected pediatric patients with traumatic cataract, trifocal toric intraocular lenses may offer some benefit over the standard monofocal lenses. This is one more study of visual preference performance with monofocal, accommodating, and multifocal intraocular lenses in patients in unilateral cataract. Mind it, I'm talking about this literature, this article about the multifocal intraocular lens. This is far now, we are reaching far more than we are reaching the trifocal, the modern trifocal IOLs. This study says in the group 2 and group 3, multifocal IOL provide better stereopsis, higher spectacles independence rates, and satisfactory functional vision over a broad range of distances in presbyopic patients with unilateral cataract compared with the monofocal and accommodative IOLs. So in the idiopathic cataract, unilateral cataract, the post-cataract surgery in unilateral cataract, the trifocality is a must, and possibilities of other eye, refractive error, if there is an refractive, but will be happy with progressive and bifocal glasses. If the patient becomes motivated for the other eye surgery, the choice of IOL should be trifocal. This is my personal one patient, which under the high myopic patients, you see the pre-op cases, pre-op the condition of the eye, and the patient was received a trifocal of 10 diopter, and the patient is getting a vision of 6, and 6. So but we are now reaching to the end of trifocal. This is a high-end trifocal now. The asymmetric stretching of the super Gaussian profile, optimized contrast and clarity is different in light conditions and tailored in wearer visual needs, and undulated of the surface reduces the halos and glare drastically compared to the traditional trifocals. So we are reaching now the end of tri. So the end of tri light distribution results in the minimum losses and optical light distribution with the conventional trifocals. We are reaching maybe this is the end of the, this is the, in time, it will be the popular end of tri. So in conclusion, operating the other eye at earliest if possible, patients wanting for refractive lens exchange is to be considered. Unilateral implantation of the trifocal IOL in patients with unilateral cataract could provide good distant, intermediate, and near vision with good patient satisfaction and vision-related daily activity performance regardless of the presbyopic status of the fellow eye. So in conclusion, treat the patient as per requirements. Should not be a biased decision or follow blindly. Patients should be provided with what is best in today's scenario. Proper planning and execution of the surgeon's skill is important. Quality should score over the quantity of the surgery. Decisions should be backed by proper evidences. And for spectacle independence, trifocal IOL is a very good option. So we have best skill, best technology, best setup, best machine, best option, high expectation of patient. So why to compromise? Thank you. Now it is the decision, it should be the decision of the House and the decision of the expert panels to choose which one, the older version or the newer thing coming in the market, or it's been accepted overall. Thank you. Thank you very much.
So now I request Dr. Kudlu for his expert comment.
Yeah, well, intraocular lens in unilateral cataract. In fact, there are two options. Unilateral cataract means after doing the trifocal, then forcing the patient for other eye to get operated is the first question. But we need to always look at, sometimes patient come to you, they just want to get operated in the only one eye. They doesn't want to operate the other eye at all. So if best available options, I think I personally feel that monofocal intraocular lens is best if you are only tackling the unilateral cataract. In fact, if you tackling...
Sir, I beg to differ because the literature says the model is 2023. The two articles as literature has come into the market, two study. This says that it's irrespective of the refractive status of the fellow eye, we can go for a trifocal. If the patients want spectacle independence.
Sir, again, there is depending upon for all these premium patient, whether trifocal or multifocal, knowing the patient's dominant eye is very, very important. Again, you need to know which eye they have developed cataract, whether in the dominant eye or whether it is in the non-dominant eye. Suppose if the patient scotopic pupil is much like a larger pupil, then if you put a trifocal in the dominant eye, the chances of glare and halos will be much, much higher. So in such cases, monofocal is the option. But thinking that, okay, preoperatively your pupil is very small, before dilated. That means you can go for trifocal even in a unilateral cataract. But the pre-op condition is also very, very important. But given an option, if you don't have any pupillometry with you and you don't have any other option to do, you don't have any other options like abrometers like eye trace, which really find out how much is the angle alpha for that particular patient, given the option, definitely I'll go with the monofocal. But all these conditions suits, okay, patient will having a cataract in the non-dominant eye, then of course I do think about trifocal.
How you check the dominance in after the patient has developed cataract?
Yeah, mature cataract you cannot know. But unilateral cataract nowadays, patient with even with up to 624 or up to 636, by putting in 660 chart, still you can get the dominant eye testing in such patient by correcting them with the spectacles. So the cataract patient, sometimes you can correct with the spectacle. Still with the correct spectacle option on, you can see the dominant eye. Once you know the dominant eye, then your option is different. Always I tell, you have to be dead on with the dominant eye. Non-dominant eye, you can play around with any ring lenses. Still brain tend to get adjust very fast. But dominant eye is the key here. I think I want my friend seen his opinion.
Personally, I've not started using presbyopic glasses. So if I develop cataract, I would go for the question here is which is better. Probably the debate was going whether the monofocal or multifocal is better. So the question is unilaterality of the cataract. So one option is asking the patient to go for multifocal in the other eye. That is definitely the option. And if it is a complicated cataract, definitely monofocal is what I'm going to go for. I would preferably, and the question is the neuroadaptation happening for the other eye. So I would personally preferably go for a monofocal eye.
So how many people of you test the pupil size and dominance of the eye before deciding the monofocal or trifocal?
I do.
Okay.
Ma'am, before...
Yes.
Yeah, this is a very good. Good question, sir. Actually, one-eyed patient, if the other eye is no PL, then I'll just look at apart from the all other conditions with the pupillometry, and if the pupil is small, definitely I'll go. If it is like depending upon their occupation, if she is a housewife, then if she doesn't want to ride the vehicle in the night and all, then I'll go for a multifocal lens, even one-eyed patient. But given me a chance, if a one-eyed patient will come to me, ask for, doctor, I don't want to wear the glasses for most of my things. My preferred choice will be EDOF lenses, preferably the EDOF lens without rings. That is one of the most preferred lens. What I use is the EMV lens from Rayner. That is, it doesn't have a ring, which normally has got a positive spherical aberration on the haptic of the lens, which gives a perfect results. And we have to tell the patient that you may have to wear the glass for a very fine print. That is my option. Otherwise, I think the best option is monofocal, again with the cases of what Dr. Srini said that. But if he doesn't want to wear the glass, male patient, active nightlife, one night, my preferred choice will be EDOF or monofocal lens again. Yeah, VVT, normally I don't use VVT. Yeah.
So the problem here is when VVT comes under enhanced monofocal, can't call it. See, most of the people are using this distance now. It's now the computer distance. So I would go for a trifocal rather than.
But VVT does not have a very good near vision.
Yeah, that's.
Yeah, every patient require a intermediate and far intermediate. It is very important. When they're driving a vehicle, they should see the meter. There is a first criteria for everybody.
Yeah, even multifocals, VR surgeons say no problem. You put it. With Bharti ma'am's permission, one query for Dr. Sharon and Sir and Nidhi. For ROC inhibitors, what would be your choice, ripasudil or netasudil?
Right.
For cornea.
Okay, so this is from both my experience and what literature says. Between the two, in the effect on the cornea in terms of detergents, in terms of helping patients who have Fuchs or one of those dystrophies, both seem similar in their effect. The problem is that the amount of epitheliopathy which is seen post their usage is much more with the netasudil drop for some reason than with the ripasudil. On the other hand, ripasudil has more patients complaining of pain, irritation, redness, and having to stop the drops. So you can still give it to your patients, but warn them that they may have redness, irritation, and in that case you will be stopping. But in terms of efficacy, both are similar.
My personal experience is different. Netasudil causes a microcystic edema.
Yes.
That's because it's stronger and the detergent's effect is better. And it's worked for me in one case. I can't tell that one case it worked, but still, it was basically, I did cataract surgery in young patient, so bilateral near mature cataract. I did the cataract surgery, endothelial recompensation. Then I thought, okay, I didn't do this because I thought something went wrong with my surgery. I used everything, Viscot and everything, did the other eye. Again, this thing. So I called up my corneal surgeon, and he asked me, sir, have you put ROC inhibitor? Yes, he has been on ripasudil. He said, try netasudil, and it cleared. Clear.
Dr. Srini, I think this is the time to wind up, and we should go for a group picture of the fast of the speakers and the panelists.